Okay, let's unpack this. Have you ever stopped to consider just how much a seemingly simple cough can tell you about a person's entire health story? It's not just a sound, a fleeting symptom. It's often a complex narrative, woven with clues about a patient's medical history, their environment, and even their emotional state. And for medical professionals, or really for anyone curious about the intricate art of diagnosis, understanding how to truly listen to that story, how to interpret its subtle nuances, is an incredibly powerful skill. Today, we're diving deep into the art and science of cough history taking. Our mission is to extract the most important nuggets of knowledge from our sources, which include a fascinating medical case study and comprehensive guidelines on symptom assessment. Think of this as your shortcut to being incredibly well-informed about a crucial foundational aspect of clinical practice.
What's truly fascinating here is observing how a symptom that seems so straightforward on the surface, like a cough, quickly unfolds into a complex diagnostic puzzle. We're not just going to talk about what questions to ask, but more importantly, why each and every detail matters, how it connects to the bigger picture of a patient's health, and crucially, how it guides us toward understanding their unique situation and finding the right path for them. It's about building a complete picture, brick by diagnostic brick.
So, whether you're a medical student looking to sharpen your diagnostic instincts, a seasoned practitioner seeking maybe a fresh perspective on a common presentation, or just someone who's incredibly curious about how doctors think and solve medical mysteries, get ready for some significant aha moments. You're about to gain invaluable insights into a crucial aspect of clinical practice that often determines the entire diagnostic journey. Okay, to set the stage for our deep dive and give us a concrete example to anchor our discussion, let's begin with a specific case presented in our sources. Imagine you're a doctor in a busy clinic and a 52-year-old gentleman walks in complaining of a daily cough that's been bothering him for a relentless 4 months. He also mentions experiencing frequent episodes of a dry nose and a constant throat-clearing sensation throughout his day. When you first hear this, what immediately jumps out at you about this initial presentation? What's the very first thing your mind zeroes in on?
Well, the very first thing that leaps out is the duration. 4 months. This raises an important question right from the start. It's well beyond what we consider an acute cough, which would be, less than 3 weeks, or even a subacute cough lasting up to 8 weeks. This is clearly a chronic cough, which immediately and fundamentally shifts our diagnostic thinking. We're definitely not looking at a simple, fleeting cold here. The duration alone is a massive guiding clue, pushing us to look for underlying, more persistent causes that warrant a systematic and thorough investigation rather than just symptom management.
That makes perfect sense. The chronicity is key. Now, what about his broader medical background? Our sources reveal he has a history of mild hypertension and is currently taking 2 medications. Lisinopril, which is an ACE inhibitor, and Ranitidine, an H2 blocker, typically used for acid reflux. He reports an unremarkable physical examination, no clubbing, no pedal edema, and normal JZP. For our listeners who aren't medical professionals, clubbing refers to a change in the shape of the fingernails, often a sign of chronic lung or heart disease. Pedal edema is swelling in the feet, and normal JVP means his jugular venous pressure, an indicator of heart function, is normal. Crucially, his recent chest X-ray was also clear, showing no obvious abnormalities. What clues do these additional details offer, particularly when combined with the chronic nature of the cough and his other complaints?
Right. Okay. So if we connect this to the bigger picture, the lisinopril immediately jumps out as a major high probability culprit. ACE inhibitors, like lisinopril, are a very common and well-known cause of chronic cough, affecting about, maybe 5 to 20% of patients who take them. The cough they cause is typically dry, irritating, and non-productive, often described as a tickle in the throat. What's crucial to remember, and what many patients don't realize, is that this cough isn't like a transient side effect. It can persist for weeks, sometimes even months, up to 6 months in some cases, after discontinuing the medication. So even if you were to stop it today, the cough might linger for a significant period. That's a vital piece of information for managing patient expectations. Then, the ranitidine, used for acid reflux, immediately hints at potential gastroesophageal issues, specifically gastroesophageal reflux disease, or GERD. GERD is another exceedingly common cause of chronic cough, even in the absence of typical heartburn symptoms. Sometimes the cough is the only symptom of reflux, what we call an atypical presentation.
Right, GERD, even without the classic heartburn.
Exactly. And the clear chest X-ray, well, it's definitely reassuring as it rules out some of the more obvious and serious lung pathologies like overt pneumonia, large tumors, or significant structural lung changes that would be visible on a standard X-ray. It gives us a baseline of confidence. However, it's really important to note that a clear X-ray doesn't rule out all serious causes, only some. For instance, early interstitial lung disease, where the lung tissue itself becomes scarred, or even some forms of asthma, which primarily affect the airways, might not be immediately visible on a plain film. So while it's a good first step, it's rarely the final answer in a chronic cough.
Okay.
And then the patient's complaint that his cough is causing insomnia, this is a critical detail. It highlights the significant impact on his quality of life. This isn't just an annoying symptom, it's profoundly affecting his daily function and well-being, specifically his sleep, which we know is foundational to health. This piece of history is vital for determining the severity and urgency of intervention, and it emphasizes that we're treating a patient, not just a cough.
This specific case truly underscores how crucial a thorough history is, even before we consider extensive or, expensive tests. It's about being a medical detective, meticulously piecing together the patient's unique health tapestry, where each thread, from current medications to daily habits, and even the time of day the cough occurs, can lead directly to a diagnosis. It's a powerful reminder that sometimes the most potent diagnostic tool we possess is simply the art of asking the right questions and truly listening to the answers. Before we dig deeper into the gentleman's case and the specifics of comprehensive history taking, our sources provide foundational knowledge that all medical professionals rely on. How do doctors typically classify a cough based on its duration? And why is this classification so incredibly important in guiding clinical decisions? It seems like such a simple starting point, but it clearly has massive implications.
Knowledge is most valuable when understood and applied, and this classification is a prime example of that. It immediately narrows down the likely culprits and helps us prioritize our diagnostic thinking. The medical community typically classifies cough based on its duration into three main categories. First, an acute cough lasts for less than 3 weeks. These are very common and are often due to a self-limiting respiratory tract infection, like the common cold, acute bronchitis, or sometimes even the flu. They typically resolve on their own as the infection clears.
Okay, less than 3 weeks, got it.
Then we have a subacute cough, which persists for anywhere from 3 to 8 weeks. This category often represents a post-infectious cough, where the original infection has largely cleared, but the airways are still inflamed and hyperresponsive, leading to a lingering cough. It's the kind of cough you might have after a bad cold that just won't seem to go away, often colloquially called a chest cold.
Right, the one that just hangs around 3 to 8 weeks.
Exactly. And finally, as in our gentleman's case, a chronic cough is defined as one that lasts for more than 8 weeks. This temporal classification is absolutely critical because it immediately directs our attention towards vastly different sets of conditions. For instance, while common causes of acute cough are those upper respiratory tract infections, a chronic cough immediately pushes us towards a broader and often more complex differential diagnosis. This can include conditions like chronic obstructive pulmonary disease, or COPD, which encompasses emphysema and chronic bronchitis, asthma, where the airways narrow and swell, gastroesophageal reflux disease, or GERD, as we discussed, upper airway cough syndrome, often caused by postnasal drip, or even more serious but less common issues like pulmonary embolism, a blood clot in the lungs, or an inhaled foreign body, especially in children, or even lung cancer. The duration acts as a powerful filter, allowing us to focus our detective work.
That distinction is so clear now. It truly helps segment the approach. Beyond just how long the cough has been going on, are there any immediate, urgent red flags related to the cough's character or presentation that would demand immediate, even emergency medical attention? What's the drop everything and act now sign?
Absolutely. This is a critical aspect of initial assessment. When taking a cough history, we're not just looking for typical presentations, we're also actively screening for signs that indicate an emergency. The presence of stridor, or a choking episode, immediately implies an upper airway obstruction. These are not symptoms to be taken lightly. They require immediate and urgent medical attention. Stridor, for those unfamiliar, is that high-pitched, harsh, squeaky breathing sound that typically indicates a narrowing of the upper airway, perhaps due to swelling, a foreign body, or even a tumor. It suggests a significant impediment to airflow. Similarly, an acute choking episode suggests a foreign body or rapid swelling that is severely obstructing the airway. These are critical signs that signify a potentially life-threatening situation where rapid intervention is paramount to secure the patient's airway and prevent respiratory arrest. So, while most coughs are benign, always be alert for these severe signs that signal an immediate life threat.
Stridor or choking.
Got it.
Critical red flags. Okay, here's where it gets really interesting and where our sources provide an incredible roadmap for taking a comprehensive cough history. It's not just about asking a few general questions. It's about being a meticulous detective. Let's break down the essential questions and observations that medical professionals need to make, moving far beyond the simple, do you cough, to truly understand the cough's unique signature and what it reveals. Let's start with the basics, but with a nuanced twist. Does the patient's age when the cough first started offer any unique insights, potentially steering us towards certain diagnoses more quickly? It feels like it could be a significant differentiator.
Indeed, age of onset is a valuable piece of the puzzle because different conditions tend to manifest at different life stages. For example, the most common cause of chronic cough in childhood is consistently asthma. So if a parent reports a chronic cough starting in their young child, particularly one that worsens with exercise or at night, asthma is often high on our diagnostic list. In contrast, in adults, gastroesophageal reflux disease, or GERD, and upper airway syndromes, which typically include conditions like postnasal drip, are far more common causes of chronic cough. So knowing the age of onset helps us immediately start thinking about specific diagnostic avenues and prevalence rates for different conditions, making our diagnostic process more efficient.
Interesting. So childhood often points towards asthma, adults more towards GERD or postnasal drip. Okay. Beyond age, what characteristics of the cough itself are important to capture? What details about the sound, the timing, or how it feels are crucial for diagnosis? It seems like the cough has its own distinct language we need to learn.
Absolutely. The cough has its own distinct signature, and we need to be fluent in it. We look at several characteristics. First, we need to understand its frequency and daily variation. Is there a particular time of day when the cough is the worst? For example, a persistent morning cough, especially one that produces a lot of sputum, might strongly indicate chronic bronchitis. This is often due to accumulated mucus overnight that needs to be cleared in the morning. It's that classic smoker's cough, but also seen in conditions like COPD. If the cough is worse at the end of the day or only occurs when they're talking a lot, that also gives us clues.
Okay, so timing matters. Morning cough, potential chronic bronchitis.
Second, a nighttime cough, or nocturnal cough, is a very significant clue that warrants specific attention. A cough that primarily occurs at night, especially one that wakes the patient from sleep, may point to conditions like asthma, where airway reactivity often increases in the early morning hours, gastroesophageal reflux disease, where stomach acid can more easily regurgitate into the esophagus and irritate cough receptors when lying flat, or even left ventricular failure, a form of heart failure, where fluid accumulates in the lungs more readily in a recumbent position, leading to breathlessness and cough. Differentiating between these is crucial.
Nighttime cough really narrows it down to asthma, GERD, or maybe even heart issues. That's a big one.
Yeah, it really is. Third, we ask about the cough in relation to meals or specific positions. Does the cough occur during or immediately after eating or drinking, or when lying flat? This often suggests aspiration, where food or liquid accidentally enters the airways, which can be a serious issue, especially in older patients or those with neurological conditions. It can also strongly suggest GERD, where reflux is exacerbated by horizontal posture or a full stomach. Asking, does this happen every time you eat or drink certain things, can be very revealing.
So linked to eating, drinking, or lying down points towards aspiration or GERD again.
Right. Finally, we inquire about the progression of the cough. Has the cough changed in character or frequency over time? Is it worsening, or is it a new problem entirely superimposed on an existing one? This can be profoundly important, particularly in a patient with a smoking history. A significant change in a chronic cough, especially a new cough, or one that's becoming more frequent, more severe, or producing new symptoms like blood, particularly in a smoker or ex-smoker, immediately raises the concerning possibility of lung cancer, demanding urgent and thorough investigation. It's a red flag that says this isn't just the usual.
Okay, change in a chronic cough, especially in a smoker, is a major red flag for potential malignancy. Very important point. So it's not just what the cough sounds like or when it happens, but also what seems to trigger it. What specific factors should a medical professional meticulously ask about that might aggravate or worsen the cough? It feels like identifying these triggers is like finding the key to the mystery.
Precisely. Identifying these specific triggers is indeed like finding a crucial key. We need to identify anything specific that consistently triggers or aggravates the cough, as this often points directly to the underlying mechanism. This includes specific activities, body positions, and environmental exposures that the patient has noticed. For example, if the cough is triggered by food or drink, or if there's a sensation of something going down the wrong pipe, it can suggest aspiration or gordo. This is particularly relevant if the patient struggles with swallowing or has any neurological conditions. If it's worse with changes in posture, like lying flat or bending forward, it can strongly indicate GERD, where gravity no longer helps keep stomach acid down, allowing it to irritate the esophagus and airways.
So posture again, linking back to Gordo.
Exactly. Exposure to irritants such as dust, pollen, animals, fumes, vapors, or cigarette smoke can significantly exacerbate symptoms, especially in conditions like asthma or chronic bronchitis. A patient might say, every time I visit my friend with a cat, my cough gets terrible, or it's unbearable when I'm doing housework and dust flies around. For someone with asthma, even cold weather or exercise can trigger or worsen their cough and associated symptoms because the sudden change in temperature or increased airflow irritates already hyper-responsive airways.
Right. Asthma triggers are classic cold air, exercise, allergens.
This really raises an important question for you, the listener, whether you're a patient or a budding diagnostician. Have you ever noticed what makes your cough worse, or what makes a cough in someone you know worse? Recognizing these patterns is incredibly insightful and often provides the most direct pathway to diagnosis.
That's a fantastic question for our listeners to ponder, because understanding those personal triggers, as you've just highlighted, is absolutely central. It really emphasizes the importance of being a meticulous detective, isn't it? It's not just asking, do you cough, but digging deep into when and where and why do you cough, to paint that full, nuanced picture. It's about truly listening to the story the patient's body is trying to tell. A cough is rarely an isolated symptom. The body often sends other signals that, when combined with the cough, can point directly to a diagnosis, like pieces of a larger puzzle. What other accompanying symptoms should we inquire about to help us connect these dots and build a coherent clinical picture?
This is where the so what really comes into play, as these associated symptoms provide crucial context and help us connect the dots, often narrowing down the differential diagnosis significantly. It's like gathering more evidence to confirm or refute our initial suspicions. First, sputum production is a major clue. We need to ask about the character, quantity, and color of the sputum, as these are highly indicative. For instance, clear, gray, or whitish sputum typically suggests chronic bronchitis, viral infections, or conditions like asthma. It's generally less concerning for acute bacterial infection. Purulent yellow or green sputum strongly points to an acute bacterial infection, such as bacterial bronchitis or pneumonia. The color comes from white blood cells fighting the infection.
Yellow or green usually means bacterial infection. Clear or white, maybe viral or chronic inflammation.
Right. More concerningly, rust-colored red or brown sputum can indicate more serious conditions like pneumonia, especially pneumococcal, lung infarction, a blockage of blood flow to the lung tissue that causes tissue death, or advanced bronchiectasis, which is a chronic condition where the airways are abnormally widened and prone to infection. Conversely, a truly dry, non-productive cough, meaning no sputum is produced, might suggest an upper respiratory tract infection, GERD, an inhaled foreign body, or even an atypical pneumonia, which might not present with the classic productive cough.
Rust-colored or red-brown sputum sounds quite serious, and a dry cough has its own set of possibilities, including GERD again.
Exactly. Next, hemoptysis, which is coughing up blood, is always a significant red flag and demands urgent attention. Quantifying this is crucial. We need to know how much blood is present, a few streaks, a teaspoon or more, and over what 24-hour period. Blood-tinged sputum could mean an acute infection or severe coughing, but it also raises serious concerns for lung cancer, left ventricular failure, heart failure leading to fluid in the lungs, or sometimes even tuberculosis. A significant amount of hemoptysis, especially bright red blood, always demands urgent investigation.
Coughing up blood hemoptysis always needs urgent follow-up. Quantity matters.
Definitely. Chest pain associated with a cough also requires careful differentiation. Pleuritic pain is sharp, stabbing pain that worsens with breathing, coughing, or sneezing. This often accompanies infections like pleurisy or pneumonia or pulmonary embolism. Central chest pain that originates in the center of the chest or radiates to other areas like the arm or jaw could be myocardial infarction, a heart attack, which is a life-threatening emergency. Musculoskeletal chest pain, often described as tenderness in the ribs or chest wall, is frequently benign but can be due to severe coughing spasms causing muscle strain or even rib fractures, particularly in older patients or those with weakened bones.
So distinguishing the type of chest pain is vital. Pleuritic versus central versus musculoskeletal.
Precisely. Dyspnea, or shortness of breath, combined with cough is another critical indicator. The onset of dyspnea is a major clue. Sudden onset may indicate a pulmonary embolism, acute pulmonary edema, or foreign body inhalation. Subacute onset suggests conditions like pneumonia, aspiration, and exacerbation of COPD, or an asthma flare-up. Gradually, progressive dyspnea is typical of chronic conditions like COPD or left ventricular failure, often accompanied by orthopnea, difficulty breathing when lying flat, alleviated by sitting up, and paroxysmal nocturnal dyspnea, or PND, waking up gasping for air at night, a classic sign of heart failure.
Wow, the onset of shortness of breath, sudden, subacute, or gradual, really points in different directions. And orthopnea and PND are classic heart failure signs.
They are. We also inquire about wheeze, asking if the patient has a whistling sound when they breathe, especially when breathing out. Wheezing often accompanies obstructive airway diseases like asthma and COPD. It can also be present in cardiac failure due to fluid around the airways, or even rare conditions like Churg-Strauss syndrome, a type of vasculitis.
Wheeze usually means asthma or COPD, but can also be heart failure. Good to remember.
Yeah. Nasal symptoms are vital to explore because upper airway syndromes, often referred to as postnasal drip syndrome, are a very common cause of chronic cough. Postnasal drip, where excess mucus drips down the back of the throat, directly stimulates cough receptors. So we meticulously inquire about nasal discharge, nasal congestion, a constant need for throat clearing, an irritation or dripping sensation in the throat, and facial pain or pressure, which could suggest sinusitis. This really raises an important question for you. Beyond the sound, how does this cough feel to you? Does it feel like something is stuck? Or an itch? Or a deep irritation?
That's a great point, the sensation associated with the cough. Throat clearing, dripping, facial pain all point towards the upper airways. Postnasal drip, sinusitis.
Exactly. Hoarseness can be another important symptom. This could indicate vocal cord paralysis, which might happen after surgery or due to a tumor, inflammation of the larynx, laryngitis, laryngeal malignancy, or even a bronchogenic carcinoma, lung cancer, involving the recurrent laryngeal nerve, which controls vocal cord movement.
Hoarseness could be simple laryngitis or something much more serious involving nerves or malignancy.
Correct. Gastrointestinal symptoms are crucial to explore, especially those suggestive of GERD, as it's a major cough cause. These include retrosternal burning, the classic heartburn sensation, regurgitation of food or acid, or a bad breath, and acid taste in the mouth, particularly when lying down or bending over.
Back to GERD again, heartburn, regurgitation, acid taste.
Yes, it keeps coming up. And finally, we cast a wide net for other important symptoms that might seem unrelated but can be critical pieces of the puzzle. This includes a recent history of upper respiratory tract infections, which, as we discussed, can lead to lingering postnasal drip syndrome. Unexplained weight loss or anorexia often suggests malignancy or advanced chronic conditions like COPD or bronchiectasis. Fever and chills point to infection. Clubbing, that characteristic change in the shape of the fingernails we mentioned, is often associated with chronic cough and can indicate chronic lung or cardiac disease. Skin rashes like erythema nodosum might suggest tuberculosis, while a purpuric rash or mononeuritis multiplex could be seen in rarer systemic conditions like Churg-Strauss syndrome, especially with asthma. We also ask about associated urinary stress incontinence, as severe coughing can strain the pelvic floor, and episodes of syncope, fainting associated with cough, which can occur due to reduced blood flow to the brain during intense coughing fits. Each of these can be a critical piece of the puzzle that helps us build a complete clinical picture, even if they seem like minor details at first glance.
Wow, that's a comprehensive list. Weight loss, fevers, clubbing, rashes, incontinence, even fainting, all potential clues linked to a cough. Beyond the immediate symptoms and associated body signals, what historical information about the patient and their family is absolutely critical for understanding the cough in its broader context? This feels like laying the groundwork for a more complete understanding.
This provides essential context, as a patient's past health experiences and genetic predispositions can heavily influence their current presentation and vulnerability to certain conditions. We inquire meticulously about two key areas. First, the patient's past medical history. This includes asking about conditions like childhood asthma, a history of recurrent chest infections, a diagnosis of COPD, any previous tuberculosis exposure or disease, and recurrent sinusitis. These conditions are not just isolated facts. They can either predispose a patient to chronic cough or be the direct ongoing cause. For instance, a history of childhood asthma means a current cough is much more likely to be an asthma exacerbation than in someone with no such history. We also need to ask about a personal or family history of atopy, which is a genetic predisposition to developing allergic diseases like hay fever, eczema, and asthma. These allergic conditions often go hand in hand and can very frequently manifest as a chronic cough. Additionally, we inquire about any pre-existing cardiac disease, vascular risk factors like high cholesterol or diabetes, or congestive cardiac failure, as heart conditions, particularly left-sided heart failure, can lead to pulmonary congestion and subsequently a chronic cough.
Okay, so Past history of asthma, COPD, TB, sinusitis, atopy heart disease, all very relevant.
Absolutely. Second, a thorough family history is equally important. We specifically ask about asthma, as it has a strong genetic component, and lung cancer, especially in first-degree relatives like parents, siblings, children. While smoking remains the dominant risk factor for lung cancer, a strong family history can indicate an increased predisposition for the patient, even in the absence of a significant smoking history. These family histories can strongly predispose a patient to certain conditions, significantly guiding our diagnostic process and risk assessment. It adds another layer to our detective work.
Family history of asthma or lung cancer adds another layer of risk assessment. Makes sense. This brings us to another fascinating area. It's not just about what's happening inside the body or what's been happening over their lifetime, but also what's currently being put into it or what's around it in their daily environment. This seems like an area where seemingly innocuous details, things the patient might not even connect to their cough, could hold significant clues.
Precisely. This area often holds surprising facts and is absolutely crucial because external factors frequently contribute to or cause chronic cough. We need to meticulously go through a patient's current medications, known allergies, and their social and environmental context. First, medications and allergies. As we saw with our opening case, ACE inhibitors are a remarkably frequent cause of chronic cough. The cough is typically dry, irritating, and non-productive, almost like a tickle in the throat. What's particularly important for you, the listener, to remember about ACE inhibitor cough is its delayed resolution. It can take anywhere from weeks to up to 6 months after stopping the medication for the cough to fully resolve. This isn't an instant fix, and patients need to be aware of this timeline to manage their expectations and avoid unnecessary further investigations. It's a classic example of a medication side effect that mimics a serious underlying disease.
That ACE inhibitor point is huge. The cough can last for months after stopping the drug. Crucial for patient counseling.
Definitely. Other medications can also play a role. Non-steroidal anti-inflammatory drugs, or NSAIDs, and aspirin can exacerbate asthma in susceptible individuals, leading to a cough. Beta blockers, used for heart conditions or high blood pressure, can cause bronchoconstriction, narrowing of the airways, and can also worsen gastroesophageal reflux symptoms, which in turn can lead to cough. Even seemingly unrelated medications like nitrates, calcium channel blockers, theophylline, and bisphosphonates can trigger or exacerbate GERD-related cough due to their effects on the esophageal sphincter, the muscular valve that keeps stomach contents in place. So a thorough medication review is non-negotiable.
So NSAIDs, beta blockers, even nitrates and others can potentially cause or worsen cough, often via asthma or GERD. Need that full med list.
Absolutely. Second, environmental and occupational triggers are often overlooked but profoundly important. We need to ask if the patient has exposure to common allergens like house dust mites, pollen, or animals at home or work, as these can be triggers for allergic rhinitis or extrinsic asthma. But it goes beyond common allergens. For professionals, it's vital to ask about specific occupational exposure to dust, vapors, animals, and chemicals, as these can cause serious and often irreversible lung diseases such as interstitial lung disease, extrinsic allergic alveolitis, and pulmonary fibrosis. Imagine a baker exposed to flour dust, or someone working with certain chemicals. Their work environment could be directly causing their cough. This isn't just about common allergens, it's about the patient's entire daily environment and history of exposures.
Occupational history is critical. Exposure to dusts, fumes, chemicals can lead to serious lung diseases presenting as cough.
Exactly. Third, social habits are indispensable. Smoking history is, without a doubt, the single most important risk factor for lung cancer, COPD, and chronic bronchitis. We need to quantify their smoking history, often measured in pack years, and also ask about passive smoking exposure, which is also relevant. Beyond smoking, alcohol intake can also worsen GERD.
Smoking history #1 risk factor. Need the details, including passive exposure.
Fourth, exposure history is crucial. Has the patient traveled abroad recently, particularly to areas where they might have been exposed to infectious diseases like tuberculosis or endemic fungal infections? Have they been in close contact with others who have similar symptoms, suggesting a contagious illness like pertussis, or who have been diagnosed with an infectious disease?
Travel history and contact history important for infectious causes like TB or pertussis.
Fifth, and this is often overlooked but profoundly important for the patient's overall well-being, the impact on quality of life. We must always ask how the cough interferes with their daily activities, their ability to work, their capacity for exercise, and particularly their sleep. As with our initial case, insomnia due to cough is a critical detail that speaks to the severity of the symptom and the need for effective treatment. A chronic cough can be debilitating, leading to exhaustion, social isolation, and even depression. Understanding this impact shapes our management goals.
Quality of life, impact, how does it affect sleep, work, daily activities? Really important for understanding severity.
Definitely. Finally, and perhaps most importantly, for establishing trust and understanding the patient's underlying perspective, we must always ask about the patient's concerns. Is there anything in particular that you are worried this may be? This acknowledges their anxiety, allows them to voice their fears, and often provides invaluable insight into their perception of the illness, which can sometimes guide our investigative priorities. They might be worried about cancer, even if clinically it's a low probability, and addressing that concern is part of comprehensive care.
Asking what are you worried about is key. Addresses anxiety and gives insight. So once we have this incredibly detailed history, this rich tapestry of symptoms, medical background, lifestyle, and environmental factors, what's the next step? How do we synthesize all this information into a coherent plan for investigation and management, especially since a clear chest X-ray isn't always the end of the story?
Right. First and foremost, after taking this extensive history, we must explain to the patient that a full clinical examination is required to supplement the history. This ensures we don't miss any physical signs that might corroborate or alter our initial hypotheses, like subtle wheezing, changes in lung sounds, or signs of heart failure. It's also incredibly important right from the start to reassure them that while many causes of chronic cough are benign like allergies, asthma, or GERD, some are indeed more serious, such as COPD, pulmonary embolism, or various forms of cancer. We manage their expectations while also being thorough.
So thorough exam first, then reassurance balanced with acknowledging potential serious causes.
Exactly. What's truly fascinating here, and a point our sources emphasize, is a powerful statistical shortcut for certain patient groups. For non-smokers who are not currently taking ACE inhibitors and who have a clear chest X-ray without obvious underlying lung disease, conditions like postnasal drip, asthma, and GERD account for virtually 90% of chronic coughs. This isn't just a statistic. For a busy clinician, this is a diagnostic shortcut that dramatically streamlines your approach. It helps us prioritize our diagnostic thinking and initial management strategies towards these common culprits, often preventing unnecessary, expensive, and invasive tests for the vast majority of chronic cough patients. It's a prime example of applying knowledge to practice efficiently.
That 90% statistic for non-smokers, non-AC users with a clear X-ray is truly powerful, points strongly to postnasal drip, asthma, or GERD. That's a huge clinical pearl.
It really is. So it sounds like for many patients, there are some initial common therapeutic trials that can be considered almost like a diagnostic test in themselves before jumping into more invasive or expensive investigations. Can you elaborate on these therapeutic trials?
Exactly. Our sources strongly suggest considering initial therapeutic trials based on the most likely diagnoses derived from the history. These trials serve a dual purpose. They can be both therapeutic and diagnostic. If the cough resolves or significantly improves with the treatment, it provides a strong indication that we've identified the underlying cause, often without needing further extensive testing.
Okay, so trying treatments for the most likely cause can actually help confirm the diagnosis. Makes sense.
Precisely. For instance, if the history strongly points towards postnasal drip, we might initiate a trial of nasal decongestants, saline nasal rinses, or intranasal steroid sprays. If asthma is suspected, especially if there's a history of wheezing or breathlessness, a trial of bronchodilators or inhaled corticosteroids might be appropriate. And for suspected GERD, a trial of antacids or more potent acid-suppressing medications like proton pump inhibitors would be a logical step. The key is to select the trial based on the most probable diagnosis from the thorough history.
Right. Tailored trials, nasal sprays for PND, inhalers for asthma, PPIs for GERD.
Also, revisiting medications is critical. Discontinuing medications like ACE inhibitors, NSAIDs, or beta blockers, if they're suspected culprits and clinically feasible, is a critical first step. Advising smoking cessation, if the patient smokes, is absolutely paramount, not just for cough improvement, but for overall long-term health. If there's a strong suspicion of bacterial infection based on sputum color or other signs, the appropriate antibiotic treatment would be indicated. A plain chest X-ray is considered essential in all cases of chronic cough. It's a foundational investigation to rule out immediate major lung pathology. If the cough remains unexplained after 8 weeks of these initial trials, or if it progresses despite these interventions, then we know we need to move to more targeted and often more advanced investigations. It's an iterative process of testing hypotheses.
So stop suspect meds, advise smoking cessation, maybe antibiotics if indicated, and always get that baseline chest x-ray. If still no answer after 8 weeks, then move on.
The source also provides a clear flowchart, a systematic visual guide. This helps to visualize the investigative pathway, ensuring no critical step is missed, doesn't it? It seems to really bring that iterative process to life.
Indeed, that flowchart is an excellent distillation of the systematic approach needed in chronic cough. It visually confirms that after the thorough history and initial management steps, like therapeutic trials, medication adjustments, or smoking cessation, if the cough is still unexplained, then the path logically leads to considering more advanced diagnostics. This isn't a random ordering of tests, it's a carefully considered progression based on likelihood and risk. For example, the flowchart guides us to consider a CT scan of the sinuses if nasal symptoms persist, or comprehensive lung function tests, PFTs, to meticulously assess for obstructive lung diseases like asthma or COPD, or restrictive lung diseases that affect lung volume. It might then suggest esophageal pH studies to definitively confirm GERD if reflux is still suspected despite initial trials. For more subtle lung tissue changes, a high-resolution CT of the thorax, HRCT, is indicated. If heart failure is suspected, then cardiac studies. And for those elusive or concerning cases, procedures like bronchoscopy for direct visualization and biopsies, or even autoimmune studies are considered. This logical flow ensures nothing critical is missed, and that investigations are guided by clinical suspicion, not just shotgun approaches. It's about being efficient with resources and minimizing patient discomfort.
That systematic approach shown in the flowchart is key, guiding from history and initial trials to more specific tests like CT sinuses, PFTs, pH studies, HRCT, bronchoscopy based on persistent symptoms. That systematic approach is invaluable. Let's zoom in on the specific investigations mentioned in our sources. What tests are on the table once we've exhausted the initial history-taking and empirical therapeutic trials, and we really need definitive answers to pinpoint the cause of the chronic cough?
Right. This section is all about getting definitive answers and confirming our diagnostic suspicions. Once those initial trials haven't yielded a clear diagnosis, we need to dig deeper. First, as part of the initial investigation based on clues from the history, we might continue or adjust those trials of nasal decongestants, bronchodilators, or antacids. They can sometimes take time to show their full effect, or we might try a different class of medication within that same category.
So maybe optimizing or extending those initial trials first.
Possibly, yeah. For physiological assessment, peak flow monitoring is excellent, particularly for suspected asthma. This is a simple handheld device that measures how fast air can be exhaled. Patients can use it at home to show reversible bronchoconstriction and significant diurnal variation in airflow, meaning their lung function fluctuates throughout the day, which are classic hallmarks of asthma.
Peak flow meter is good for diagnosing asthma by showing variability and reversibility.
Exactly. Then we move into laboratory tests, which help us find systemic clues. Sputum culture, microscopy, and Zeal-Nielsen stain are crucial if infection is suspected, especially for identifying bacteria or mycobacteria like tuberculosis. Blood tests are also valuable. A white blood cell count and C-reactive protein, CRP, can indicate infection or inflammation. Eosinophilia, an elevated level of eosinophils, can be seen in allergic causes like asthma and in systemic conditions like Churg-Strauss syndrome. An elevated erythrocyte sedimentation rate, ESR, may indicate general inflammation, malignancy, or a generalized inflammatory disease. Serum calcium and serum ACE levels are important for screening for sarcoidosis. Additionally, anti-neutrophil cytoplasmic antibodies, ANCA, may be positive in Churg-Strauss syndrome. An arterial blood gas analysis can assess for hypoxia and the severity of respiratory distress, providing an objective measure of lung function.
Okay, lots of lab tests there. Sputum tests for bugs, bloods for infection, inflammation, WBC, CRP, ESR, allergy or Strauss, eosinophils, ANCA, sarcoidosis, calcium, ACE, and assessing oxygen levels, AVG.
Right, a whole battery depending on the clinical picture. In terms of imaging, while a plain chest radiograph is performed in all chronic cough cases as a first line, if it's clear and symptoms persist without an obvious diagnosis, then a high-resolution CT of the thorax, or HRCT, may be needed. This provides much greater detail and can identify subtle interstitial lung disease, bronchiectasis, or other subtle parenchymal changes that a plain X-ray would miss. A CT of the sinuses may also be necessary to investigate nasal pathology, like chronic sinusitis, if upper airway symptoms are prominent.
So if the chest X-ray is clear but cough persists, HRCT of the chest for subtle lung disease or CT of the sinuses for nasal issues might be next.
Correct. Lung function tests, especially spirometry, are crucial for objectively identifying obstructive lung diseases like COPD and asthma, or restrictive lung diseases, which indicate problem with lung volume and expansion. Spirometry involves blowing into a machine to measure how much air you can breathe out and how quickly.
Spirometry is central for diagnosing obstructive diseases like asthma, COPD, or restrictive diseases.
Yes. For more direct visualization or tissue sampling, fiber optic laryngoscopy and bronchoscopy are indicated in specific persistent situations. This includes suspected malignancy, allowing for direct visualization of lesions and biopsies. They are also used for interstitial lung disease to obtain bronchoalveolar lavage fluid or lung biopsies. For recurrent chest infections, they can obtain bronchial washings for microbiological identification of specific organisms.
Scopes like laryngoscopy and bronchoscopy are more invasive, reserved for suspected cancer, interstitial lung disease, or difficult-to-diagnose infections, allowing direct visualization and biopsies.
Precisely. Finally, for gastrointestinal causes, an upper gastrointestinal endoscopy or a 24-hour esophageal pH monitoring can definitively confirm gastroesophageal reflux disease, especially when the cough is the primary or atypical symptom of reflux. This latter test measures acid exposure in the esophagus over a day.
And for tricky GERD cases, endoscopy or 24-hour pH monitoring can provide the confirmation. That's an incredibly comprehensive rundown of the diagnostic tools available. And just to tie it all together with a common term often heard in relation to chronic cough, what's the precise medical definition of chronic bronchitis? It's a term that gets thrown around quite a bit.
That's an excellent point, as chronic bronchitis is a specific diagnosis within the umbrella of chronic cough. It is a clinical diagnosis, meaning it's based on symptoms, and it's not necessarily caused by an active infection, although infections can certainly exacerbate it. Chronic bronchitis is defined clinically as the persistent cough that produces sputum and mucus for at least 3 months in 2 consecutive years. So it's not just a passing cough, it's a recurring, productive cough over a significant period. It's important to remember that specific definition, as it often comes up in discussions about chronic cough and COPD.
Got it. Chronic bronchitis. Clinical diagnosis, cough with sputum, 3 months a year for 2 consecutive years. #tag outro. Well, you've just received a masterclass in cough history taking. We've journeyed together from a patient's initial complaint, walked through a maze of subtle symptoms and crucial historical clues, all the way to a comprehensive diagnostic and investigative plan. It's truly fascinating how much intricate information can be gleaned from what seems like such a common everyday symptom.
If we connect this to the bigger picture, it really highlights that medicine is often about far more than just ordering tests or prescribing medications. It's about asking the right questions, the specific right questions, patiently listening, and meticulously connecting seemingly disparate pieces of information to form a coherent diagnostic picture. Knowledge is most valuable when understood and applied, and this deep dive provides a powerful framework for that essential clinical skill, transforming a seemingly simple symptom into a complex yet solvable medical mystery.
So what does this all mean for you, whether you're on the front lines of healthcare or just intensely curious about how the human body works? It means that even the most common of symptoms, like a cough, holds a wealth of information that, when properly extracted, can lead to precise diagnoses and incredibly effective treatments. But only, and this is key, only if you know how to ask the right questions and how to truly listen to the often subtle answers. It truly underscores the depth, the art, and the science required in modern medical diagnostics.
This raises an important question. If a common symptom like a cough requires such a detailed, multifaceted approach, what other seemingly simple symptoms might be hiding equally complex and revealing stories, just waiting for a deep dive to uncover them?
Something to mull over as you go about your day.
Yeah.
Thank you for joining us on this deep dive into cough history taking. We hope you feel far more well-informed and perhaps a little more curious about the hidden stories our bodies tell us every single day.